ventilation is an important part of tear production and tear biology. Well, when you're asleep and those eyes are closed, the corneal nerves aren't sending the signal, hey, I need more tears. The air through the nasal passages are stimulating the nasociliary nerve, which stimulates your tear production. Is that going to be a problem if you're a mouth breather?
Yes.
Yes, right? Is that going to be a problem if Mother Nature's had its way and things are sagging just a little bit?
Yes.
Is that going to be an issue if everyone in your family has kind of a flat mid-face or really prominent eyes or inferior scleral show? Do you think those are situations where exposure might be a problem, where airflow might be a problem? What about our CPAP patients? What kind of airflow problems do they have? It's crazy, right? There's so many things. I can't tell you how many times I've gone to do, you have sleep apnea? Yeah, I can see that. I don't know how many times I've examined a patient, going to do their dilated exam, grab that upper lid to kind of peek under there, like, wait a second, I shouldn't be able to pull that behind your ear. No, I'm exaggerating, but the point is that floppy eyelid syndrome is highly, highly correlative with sleep apnea. So when you have that finding of temporal lactosis, excess laxity, and papillary conjunctivitis changes, send your patient for a sleep study. If they can get on a CPAP, it will change literally it gives them 10 years longer life if you catch it and treat it early. Some of the changes are somewhat reversible because what's happening is those hypoxic episodes at night are creating the smoldering inflammation process around the connective tissue around your eyelids. So that collagen that gives us our firm skin texture, not so much anymore, but that goes away with chronic inflammation and MMP9 chewing up your collagen fibers. Same as conjunctival collasus folds. That's in response to chronic inflammation. MMP9 chews up the collagen type 2 fibers that are attaching the conjunctiva to the underlying Tenon's capsule. It gets into some pretty complex pathophysiology at night when we're sleeping. That humble little muscle light that's sitting in the stand, not used much of the time, that humble little muscle light, just grab that guy out of the stand, turn the lights off in the room, say to the patient, close your eyes, shine that light right at the superior sulcus, pointing at the interpalpebral fissure. If you see light escaping between the eyelids, that's an inefficient lid seal. There's a $60 fix for it. We have these brilliant masks that are durable, they're soft, and even if you're a face sleeper, which I don't recommend if you're a dry eye patient, you don't want to be like all night long. You want this to gently sit on the face. You don't want to raccoon them in the morning. Just gently sit on there, creates a moisture chamber, protects that cornea all night when you're sleeping, replicates what a natural eyelid should be doing at night when you're sleeping. Amazing. Wash it every morning in a simple non-perfumed soap. This also works great as a wash because bacteria and yeast love a warm, moist environment. That's a great question. So the question is, can this help in patients with recurrent corneal erosion? Absolutely. Particularly if their RCE is because of inefficient lid seal, right? We're just recreating that moist environment. We actually ask patients, are you a side sleeper, face sleeper, or back sleeper? Why would that matter? List the reasons off why that would matter. Your sleeping position at night. So at night, if you're a face sleeper, you have the potential to pull those tissues enough to where you've got exposure. This is comfortable even for side sleepers, the way it's designed. Helps to protect that area. Floppy eyelid syndrome patients are much more prone to that traction at night when they're side sleeping. What happens when you sleep on your back? You tend to open mouth, catch flies. All of these things matter and all these things add up, and you can't control it because you're asleep. And with this little strategy, you can protect those peepers in a moisture-loving, protective way, right? So think about it for your young patients, exposure patients, recurrent corneal erosion patients, the young people with nubbins for meibomian glands. Make sure you're looking for lid seal insufficiency. You'll be shocked at the correlation. And that was described by Corbin Blackie. Not responsive to all the therapies. High correlation with this lid seal insufficiency problem. Here's your affordable fix. Patients with dry eye spend a lot of money, and not all of it's targeted and specific and direct. This is, and it's affordable. Sometimes after a blepharoplasty that's got a beautiful cosmetic result. That scar hasn't matured and it's kind of stiff, and you can come along with things like IPL while you're protecting the surface while there's healing. Soften up those tissues, create some scar remodeling, soften that lid, and now you've restored those normal mechanics of the lid, normal protection of the lid. So think of it for short-term problems, long-term problems. Stop and think about nocturnal exposure. It's such an easy thing to identify. Literally takes you less than 60 seconds. Such an easy thing to fix. Comfort, reliability, hygiene, ability to adapt to different anatomies. Like if you have a small face or maybe even a kid, they might really like these. Oh, I really like these. Oh man, that's awesome.